Good morning or good afternoon, everyone, depending on where you are joining us from, and welcome to today's webinar titled How Including Cognition as a Safety Endpoint Provides a Competitive Differentiator. I'm Rita, and I'll be providing you with some housekeeping information before we start. Firstly, could you please send your questions throughout the webinar, and we will allocate some time at the end of the session to address any questions or thoughts that you may have. If your question doesn't get answered today, it will be available to be answered at a later stage. And for any related content on the webinar, please click on the help icon shown on your screen. And for any tech issues, please click on the help icon. And now please allow me to welcome Francesca.
Hello. So I'm very delighted to join you today to talk about cognition as a safety endpoint. And just to get the introduction started, I'm joined today by my colleague, Dr. Kenton Zavitz, and Dr. Lynn Webster. So Dr. Zavitz is our Director of Clinical Affairs. He's been with Cambridge Cognition now for nearly 10 years. And before that, he completed a PhD in biochemistry and molecular biology, following which he gained more than 18 years of biotechnology and pharmaceutical experience and was involved in all aspects of the industry, from drug discovery and clinical development through to pre-commercialization. I'm also delighted to welcome Dr. Lynn Webster, who's Executive VP of Scientific Affairs at Dr. Vince Clinical Research. He earned his Doctor of Medicine from the University of Nebraska and completed a residency in the University of Utah's Department of Anesthesiology. He's a board certified in anesthesiology, pain medicine, and addiction medicine. So just to get this webinar started, and I hope that we're going to have some interesting discussions as part of this, I just wanted to start by providing a very basic definition of what do we mean by cognition. So fundamentally, cognition is the ability to receive, interpret, process, and act on information from the environment. There are lots of different domains involved in cognition, but we tend to also think about cognition as a unitary thing. If we look at cognition in the domain of safety, it's fair to say that cognition hasn't been systematically evaluated in this field. We see from a recent literature review completed this year that in fact something like only 7% of clinical trials in new compounds have evaluated cognition. And furthermore, they've taken this very unitary view of cognition rather than looking at separable cognitive domains. So this has been approached either through the lens of patient self-report or by using instruments such as the mini mental state exam or other pencil and paper scales, which are really designed for the screening of dementia or mild cognitive impairment, rather than a detection of drug events in phase 1 or phase 2 studies. So with that kind of challenge in mind, I'm going to pass on, first of all, to Dr. Kenton Zavitz, who's going to give us a bit of an overview of why we might want to measure cognition in clinical trials, some of the limitations and recent advances in the assessment of cognitive safety in drug development. So Kenton, I'm handing over to you now.
Thank you so much, Francesca, for that introduction. And it's my great pleasure to speak about a topic that I have a great passion for. This is something that I think is becoming more and more on top of mind for regulators, physicians, patients, as well as drug developers. And so assessing cognition and the specific domains of cognition is an important way to think about completing our safety and tolerability profile. Ideally, the earlier, the better. I'll talk a little bit about the regulatory position currently in the US and with other regulatory agencies. And it's also a way to commercially differentiate your product from others in a very competitive marketplace. So as I mentioned, it's best to start thinking about this early on in development. In addition to getting a good sense of if you have any safety concerns around cognition, it can also help you with things like dose selection, patient patient population that's appropriate for phase 2 and phase 3, and can also help you understand how your drug development program interacts with the disease state in a unique way. Another reason to think about doing this, and we'll talk a little bit more about this, is that there's reason to think that if you are treating the underlying symptoms of disease, you may actually show a benefit in cognition, depending on the specific disease state that you're working with and the mechanism of action. And then thinking about these studies, it's very important to consider when looking at special populations. So in particular, younger subjects that might be taking a drug throughout their childhood while their brain is developing and into adulthood, and also the elderly, which is another cognitively vulnerable population, and we'll talk a little bit more about that. So, as I mentioned, there is a regulatory guidance that came out in 2017 in the context of evaluating your ability to operate a motor vehicle, something that obviously takes a lot of cognitive skill and coordination. So the direct quote from this guidance is that beginning with first-in-human studies, all drugs, including both those intended for non-CNS indications as well as CNS indications, should be checked for cognitive adverse events, CNS adverse events. And they go on to emphasize that what they're looking for is very sensitive cognitive tests that look at specific domains, things like reaction time or psychomotor speed, things like effects on attention and on different aspects of memory and thinking. So all of these pieces of the cognitive puzzle are something that regulators are very interested in, especially in certain circumstances where there's reason to be concerned about the mechanism of action, the patient population, and reasons that there may be some worries about cognition. So how are we doing as a field? Well, as Francesca mentioned, not great. This is a paper that came out this year that basically has said in the past, over the last 10 years, they surveyed the literature and found that only about 7% of clinical trials assessed cognition in the context of safety. Most of those used inappropriate, insensitive instruments like the MMSE that Francesca mentioned, and even CNS drugs were just over 13% looking at any effect on cognition. So the conclusion of these authors, who are specialists in the field, really feel like there's an urgent need for all parties involved to be paying more attention to cognitive safety during drug development. So what are some examples of disease states where cognitive impairment can be affected or present? The ones on the left-hand side are ones that we're all going to be familiar with when we think about cognitive impairment: Alzheimer's disease, schizophrenia, Parkinson's disease, ADHD. But as we move to the right, these are also some disease states that can have effects on cognition. So things like cancers, things like multiple sclerosis, cardiovascular diseases, obesity. All of these can come with both mood disorders, but as well cognitive impairment. So by treating the underlying disease state, if you're having a good effect on the disease, you may actually see some improvement in various cognitive domains of interest. What about the kinds of compounds that might be affecting cognition? Well, pretty much, even those that don't directly affect the CNS maybe are modulating aspects of heart function or breathing or the immune system or cholesterol or metabolism. All of these, glucose transport, all of these can actually also have impacts on cognition. Both potentially positively, but also negatively as a side effect. So again, this is something that we need to start thinking about early on as something that warrants monitoring during the development process. So an example of a couple of drugs that actually treat diabetes by stabilizing plasma glucose levels, two completely different mechanisms of action. But when you look at their effect on episodic memory, what you see is a very nice correlation between the stability of glucose with either one of these drugs and improved performance on episodic memory with a sensitive cognitive assessment. So again, even in a disease state where the primary endpoints are going to be very different from cognition, you may actually be able to show some kind of benefit. Equally, the concern might be that if you have a disease state that is causing some cognitive vulnerability, potentially that could be exacerbated by an additive effect. And we'll look at an example of polypharmacy to make that point. One other thing to consider is that the ability of a drug to cross the blood-brain barrier. So normally the blood-brain barrier is both keeping drugs out and it's also full of, in the membrane, pumps that pump drugs back and away from the brain. However, the blood-brain barrier itself can be compromised by certain types of medical conditions. So things like hypertension, diabetes, Alzheimer's disease, infections like HIV, mechanical injury like stroke and traumatic brain injury. Some medications can affect the ability of the blood-brain barrier to keep drugs out, either by inhibiting those drug pumps or through other mechanisms. And also the environment is full of unknown toxins that can affect blood-brain barrier itself. And then again, our special population of the elderly. The aging process itself can downregulate some of those pumps that are keeping drugs away from the brain, and other mechanical effects on the blood-brain barrier are exacerbated in the elderly. So this is a special population where we really need to think about effects on cognition, especially with drugs that are going to be taken long-term. So it's not just what the characteristics of your drug, but it's also the characteristics of your disease and your patient population that you need to be thinking a lot about. And then the effect of polypharmacy. So we know that, and this is a growing problem, that the elderly in particular, in the United States, 30% of them are on 6 or more concurrent medications, some of which are interacting with some of those blood-brain barrier pumps, interacting with themselves, and can have synergistic effects on cognition. So this is just a PK/PD study where we're looking at change in reaction time in milliseconds, and we have 2 drugs, a benzodiazepine and an antipsychotic, which by themselves have a very small effect, maybe 40 milliseconds of delay in processing speed. But when you put them together at the same dose, what you see is a synergistic effect on reaction time. And so one of the ways about thinking about this, obviously this is a delay of about 175 milliseconds. That's the equivalent of, if you're driving on the highway, our car length of stopping time. So even though 175 milliseconds is barely a blink of an eye, it's a very small amount of time, it's also something that can have significant consequences in real life. So again, we have to be thinking about the drugs that we're developing in terms of what else are they going to be commonly combined with, and is that something that we should be looking at in a drug-drug interaction study with potential effects on cognition. So those are some of the reasons that we want to look at cognition during drug development. How do we do it? As Francesca introduced, some of the tools that are commonly used are really appropriate for that. And what we want are sensitive, objective tests that can be utilized in any clinical setting, that don't need specialized trained neuropsychologists, that aren't paper and pencil and are being scored with the potential for adding noise with human errors and transcription. We want something that can accurately measure reaction time, as I mentioned, at the millisecond level, so that we get a good sense of that there's no sedating effect of concern. One of the things about computerized tests is they're often actually enjoyed by the participants. So we get good subject engagement. And increasingly, these tests are available not just on touchscreen iPads in the clinic, but also they're available to be used remotely on bring your own smartphone devices. And so it gives us a whole other level of being able to do long-term studies without the added cost of bringing somebody into the clinic. Another advantage of computerized testing is that a lot of times these tests are language and culture independent. So if you're doing a global study, and I'll give a couple examples of those, you don't want to have multiple different versions of a pen and paper test in 15 different languages if you're doing a study across 50 different countries. The technology is developed to the extent that we can now do these at home, we can do these on the phone, and we can gather real-world long-term data. So how do we go about putting together a cognitive battery appropriate for safety? Well, we want tests that have these characteristics, that they have good psychometric properties, so they have good test-retest ability. They're appropriate for the study population, so they can they be done by a 5-year-old in a pediatric safety study? Can they be done by a 95-year-old in the context of a drug for mild cognitive impairment or some other disease that we're studying in the elderly? Are these tests sensitive to known drugs that have effects on cognition? And often we are using tests that are sensitive to the clinical condition. If you're working with a Parkinson's disease population, for example, and are they sensitive to change over time? Can you actually do these tests in the setting of PK/PD studies where you might be doing multiple assessments in a day and trying to coordinate at peak blood concentration levels? And also importantly, do these tests relate to functional activities? So do they have clinical meaningfulness to the patient, to the physician, to the family member? So all of those things are ways that we look at selecting the tests that might be appropriate. And so to come back to the regulatory guidance from the FDA, we want tests that are sensitive and that are keying off the key cognitive domains of interest and can be administered in a relatively short period of time. So these are 5 tests that I would give it as examples. Sometimes we might only be using one of them. Sometimes we might be using 2 or 3. So in 15 or 20 minutes, you can do an assessment. You can also do a phone-based assessment with the digit symbol substitution task on a smartphone, and that takes less than 2 minutes to look at, and that gives a very broad assessment of cognition. Again, automatic scoring put into a database remotely from no matter where the subject might be. So these are the kinds of tests that we might be using, something that looks at reaction time. Working memory is another key domain, episodic memory, and then sustained attention, another important aspect of the ability, for example, to operate a motor vehicle. It's also important that these tests, we know how they operate in healthy populations of different ages. So we know that these tests are sensitive to that the developing pediatric brain is going to be improving in these tasks. And here we can see different decades of age that we have a slow decline, unfortunately, in our cognitive abilities, whether it's kind of a linear decline of working memory a more abrupt decline of episodic memory in our 70s and 80s, or a slight decline in our reaction time. So it's important to know what these domains are doing in normal human aging so that we can understand how does that compare to any effect that we might see on the drug? How does that compare to a deficit that we might see in a specific patient population? And so here's some examples of a dozen or so drugs that are being assessed with these tests. So each color represents a different test. Again, episodic memory, working memory, psychomotor speed, or sustained attention. And as you can see, each of these drugs has a different measurable effect. Some of these are very small and probably not clinically meaningful. Others are larger in effect size and may be thought of as clinically meaningful things that might count as an adverse event or something to be monitored. So again, it's important to have tests that can pick up these differences, whether they're large or small, in a very sensitive, repeatable, and accurate way. Once we do see those differences, how do we decide whether they are of clinically meaningful? And our approach typically is to use sort of a series of benchmarking arguments. How does this deficit compare to, let's say, 10 years of aging? Or how does it compare to an elderly person that is exhibiting mild cognitive impairment by a clinical diagnosis? How does it relate to these different activities of daily living, or subjective responses of the subject themselves, whether they're noticing an effect that they might talk about as brain fog or poor memory or amnesia. So there's a number of different ways. How do these drugs compare to known CNS active drugs like the ones I just showed you, or alcohol or caffeine? And another thing that is often having an impact on our cognition is sleep deprivation, whether it's being done in a study or in a sleep disorder. And so all of these are ways of thinking about how do we define what's a meaningful and concerning cognitive deficit. So I just wanted to cover a few case studies that we've been involved with, looking at these domains, and in examples from phase 1 to phase 4. So the first one is a recent study that we did with psilocybin. So as you know, there's a lot of psychedelic drugs that are being tested in multiple different indications, whether it's depression, PTSD, substance abuse. There's lots of different indications, lots of different patient populations. And these typically are treatments with single doses, and then during a psychotherapy session. And then once the person goes home, we want to know that they're not having any cognitive deficits. So this was a study with 90 patients approximately. They looked at cognition at baseline, and then 8 days from administration of the dose, and then 29 days to see if there are any significant or differences between the placebo group. And in this study, there really were no differences between any of the groups at either of the time points. So this is consistent with what, when you look in the literature, most psychedelic drugs actually, that may be counter to what people actually think, most of them do not have detrimental effects on cognition, either in the shorter term or the slightly longer term. And obviously 29 days isn't that long, but we can also monitor these differences over the long term with remote technology now. So another example of a study that we did was looking at an extended release version of guanfacine in children and adolescents aged 6 to 17. So we use this reaction time test and also a test of working memory and executive function. We saw no differences in this patient population, so the absence of any impairing effect. One of the things that was of concern and made the primary endpoint, this psychomotor speed test, was that whether the clinical benefit being seen was due simply to a sedating effect. And in this study, they found that there was no effect on sedation as measured by a psychomotor processing speed and reaction time. Another example of a study that we did in an adolescent population was in adolescents with migraine using topiramate. And in this case, we did multiple different cognitive assessments looking at working memory and episodic memory and reaction time and attention. And we did find in this case that topiramate caused a psychomotor slowing. There was a little bit of a delay in reaction time. And so this actually is an example of something that's mentioned on the label as a cognitive AI, adverse event. So again, it's important in particular to when you're studying drugs that are going to be used potentially for a long time in adolescent populations whose brains are still developing, to really understand the effect that your drug might be having on cognition. Another example of a study that was done, this was now a global study in 340 sites in 29 countries with 14 languages. And this was a study done by Amgen with a LDL lowering drug, the first in class antibody that lowers LDL levels to those that are lower than what we normally see in nature. So this was, by definition, a mechanism of action that was of interest to regulators. There was also a long history of 30 years of post-marketing reports with statins where there were concerns about effects on memory, amnesia, different reported effects. But this wasn't really never studied during the drug development process in a prospective way. So in fact, in 2012, based on those post-marketing reports, statins as a class got a black box warning about effects on memory, despite the fact that there was never dedicated studies done. So in this case, almost 2,000 patients were studied for 19 months. All of them were on a statin, and then they were also given the drug of interest evolocumab. And in this case, we were able to demonstrate, and the data is shown here, basically no differences. And they actually got on the label, based on this data, non-inferiority to placebo for a sensitive battery of neuropsychological tests. So in other words, this is a very, very high bar for a safety endpoint and language. Non-inferior to placebo is not something that you often see when reporting safety. There was a very similar study done to this with another drug in this class done by Regeneron, 2,000 patients, again for 18 months, and they also showed non-inferiority to placebo. And then a subset of these patients were actually followed for up to 7 years. And as you can see, complete flat line on any changes in cognition, whether it's working memory or executive function, which were the primary endpoints. So again, long-term studies that on drugs that you're going to be taking possibly for the rest of your life are important to know that there's no creeping effect on cognition over time. So I just wanted to finish up with a couple of comments that outside of CNS indications, there's more and more interest on brain fog in oncology. I talked about a couple of examples of cardiovascular disease. The very new and popular drugs that are in the GLP-1 agonist class, treatment for diabetes and obesity, these are actually starting to show that there may be reason to think they have cognitive benefit, and they're being tested as a therapy potentially for Alzheimer's disease. There are lots of rare diseases that have developmental issues that cause cognitive disability. Some of them are in pediatric indications, and so we look at a lot of these kinds of areas. Have a lot of sponsors coming to us in the rare disease category, and as I already mentioned, psychedelics are another area where these drugs are being investigated for cognitive safety. And finally, always think about the special populations that are cognitively vulnerable, long-term drug administration, long-term cognitive safety, and then drug interactions, as I mentioned. So I just want to leave you with sort of a summary that in the past, there was very little attention being paid to this. Inappropriate tools, self-reports, case reports, and that meant that we were missing a lot of safety signals and potential for cognitive efficacy. Now, regulators, physicians, and patients are more aware of this. We're doing a lot of these studies from phase 1 to phase 4, and we're also able to use technology to do this in real-world settings with things like smartphones and even tests on watches. And then there's a whole other area of technology with voice-based systems that look at speech and language, and we're working in that area. Probably we'll have another whole session dedicated to that in the future. So thank you so much for your attention, and I know we're going to take some questions at the end. I'm going to turn it over to Dr. Webster.
Thanks, Dr. Savitz. That excellent. I'm going to take one of the domains that Dr. Savitz had identified as an area in which there's been a paucity of research and understanding about cognitive impairment. And that is in the area of pain primarily. This happened to appear in Anesthesiology News, this headline here just last month. Postoperative delirium common in patients with pre-existing cognitive impairment. But how often is there cognitive impairment in people undergoing surgery? We know there are about 50 million operations done annually, so there are a lot of people subject to the anesthetic or the surgery itself and the underlying disease. In this particular report, which was an abstract, they had indicated that up to 75% of the patients with pre-existing cognitive impairment might experience post-op delirium. They've developed a protocol that really promotes a better understanding of who is at greater risk for post-op delirium, which has great risk, particularly safety concerns post-op. So it's important to know who's at an increased risk of post-op delirium. About 50% of the patients that were elderly, above the 60 years of age, scheduled for an operation have some level of preoperative clinical cognitive impairment, and about a fifth of that population develop POD, postoperative delirium, which indicates that there's a significant research gap in our understanding of the relationship between a surgery, the anesthetic, the surgery and anesthesia, and the incidence and severity of post-op delirium. So let me back up a little bit, just talking about the prevalence and the impact of chronic pain. I think in the US, we know that about 100 million Americans have chronic pain, and there are probably 20 million or more that have significant disabling daily chronic pain, all of which may be contributing factors to cognitive impairment. And it's estimated that the prevalence of chronic pain above the age of 65 is going to increase significantly in the next few years, where today maybe 50 million people, but we could double that by the year of 2050. So there are several neurocognitive processes that are known to influence this experience. We know that attention, memory, social and emotional processing are all components that go into cognitive states of mind. And these are all influenced by pain, the severity and the intensity of pain, the duration of pain. One way we think of the effect of pain on our experience of pain is that the experience is really the sum of all of life's experience. And so these are environmental factors as well as medical conditions that contribute to an evolution of the cognitive state of an individual. So we also have to take into consideration the different clinical phenotypes. Is it a neuropathic, inflammatory, nociceptive? Is it segmental? Where is it? And is it due to tissue injury? Or has it spontaneously occurred? What's the chronicity? Where is it located? Centrally, peripherally, or a combination, and its intensity. So the other important point about pain, like cognition, this is not a static state. Over time, it requires us to longitudinally evaluate the condition and particularly the cognitive implications of pain over time. And there is a bidirectional impact of cognition and pain. So for more cognitive impairment, there may be greater pain, and in people with greater pain, there may be more cognitive impairment. And there's very little research, as I'm going to discuss here in a minute, to demonstrate those factors. Some research has been demonstrated in a study of about 10,000 adults, a longitudinal study of individuals 62 years of age with persistent pain experience greater cognitive dysfunction when compared to subjects without persistent pain. That makes sense, right? The Framingham Heart study revealed that the presence of widespread pain at a single assessment was associated with increased risk of dementia 10 years later. So just one mention of chronic pain could predict that there could be some form of cognitive impairment 10 years later. Other studies have shown greater than 50% of the adults with chronic pain, not just limited to older adults, can experience impairments in everyday cognitive functioning, including the working memory and attentional functioning. Many of these are not picked up by some of the standard screening tools that we use clinically. There are other multiple studies that have observed positive correlations between pain intensity and dementia severity, suggesting, again, this bidirectional relationship between pain and dementia. So think of it conceptually here, the link between pain and cognitive outcomes. You can have exposure to either pain or the treatment of pain with a central acting analgesic. It could be any drug, actually, and it could even be a peripheral one. The net outcome is cognition, but there are mediators and confounders, as well as genetic predispositions, like for Alzheimer's. In an early Alzheimer that may have a genetic link, obviously can affect this in people who may also have pain and who are on medications for the treatment of pain. They may have other social dynamic issues that could enhance the effect of the drug on impairing cognitive function. So as a dynamic process, this is something that there's very little data for us to look at to understand what the risk of the drugs are on different pain states in its evolution. So we know central acting analgesics have been well documented to cause AEs and can cause significant cognitive impairment. The chronic use can accumulate. There can be a summation or there could be an improvement, depending upon what the drug is and what the pain state is, as has been pointed out. So the cognitive effects are difficult sometimes for us to differentiate between the medications, the pain, and the underlying conditions that are causing the pain. And then, as was just illustrated with polypharmacy, there's sometimes a synergistic effect on contributing to the dementia risk or cognitive dysfunction. I'm going to review two case studies. showing the difference of medications on some of the results from cognitive testing. This is first a randomized double-blind four-way crossover study of healthy subjects, a small number, and to examine the cognitive and psychomotor effects of repeated oral doses of dextropropoxetine and morphine. And here, battery of tests, which is essential if we're really going to understand the effect of a drug on cognitive functioning. The results of this is interesting because the lorazepam impaired the speed of responding on all tasks, recording speed with the exception of digital vigilance, and increased subjective ratings of calmness. Well, we'd expect the calmness with lorazepam. But then morphine increased the accuracy of responding on the choice reaction time task at every assessment. And dextropropoxetine impaired performance on the choice reaction time and picture recognition. The point here is that here are three different drugs often used in the pain state, in people with pain, chronic pain, sometimes even acute pain, but it requires a battery of sensitive tests to ferret out, basically, whether or not there is an impact on cognition and what type of impact they may occur. So every drug might have to have a more sophisticated battery of tests in order to know what clinically it means and in order to provide that safety level that we're looking for with these medications. And the second example is with a placebo-controlled randomized study in generally healthy adults, although they did have pain conditions, menstrual pain, back and joint pain. But the purpose of this study was to give an analgesic with and without caffeine and compare this to placebo. Now, this study was never completed because there was a breach of data transmission and recording. But it was still a published paper because of the concept and the methodology that they were suggesting that could be used in evaluating drugs that are not primarily centrally acting. They used the CANTEB neuropsychological test and also a mobile version of a simple reaction test. The primary outcome was to look at cognitive performances during pain versus a pain-free state. I'm not sure how they intended to get a pain-free state in somebody with a chronic background of pain, but the intent is to take a look at pain versus pain-free state and the impact that an analgesic may have on that condition. Okay, so most pain assessment tools in adults are dependent upon really somebody who has a normal cognitive function. And as I've just pointed out, particularly in that population that's going in for surgery, there may be a fifth of the population that are elderly individuals who have cognitive impairment. And this is probably even it is probably even a higher number of people that have some level of cognitive impairment who have chronic pain, whether it is due to non-cancer or cancer pain. So obtaining a cognitive status before treatment is important, but also understanding what that might have on the evaluation of cognition over the long term is also important. And we need to have scientifically based tools, not sometimes these screening tools that I frankly used all of the time because that was something practical that we can use in our clinic. But in drug development and also with some interventions, I don't know if there's anybody listening who is a part of the interventional team, but spinal cord stimulations, other treatment modalities for pain may relieve enough pain that it could positively impact cognition. And there's little to no data that I'm aware of in that field. So I want to itemize or list some of the research gaps that currently exists that we need to fill in time. And I will state that I think that there are almost an infinite number of ways to go forward, and that we need to have clarity on. And we have to be practical about this, kind of take a look at it at a 60,000 foot level and just start to nip a little bit at some big pictured ways of addressing this. But we need to have validated tools of assessing pain at different cognitive levels. And because the current screening tools are not very accurate, but if that is what we're using, we need to still have some validated tools at the different cognitive functioning levels. And most studies, as I say, rely on the screening rather than the formal neuropsychological tests. This limits our ability to understand, as I just pointed out with the lorazepam morphine study, the real effect that these drugs may have in the different domains of cognitive functioning. So the factors that may confound, mediate, moderate observed relationships between pain, central acting analgesics, and cognition are not really well understood, and we need to understand these different domains of potential mediators with cognition as well as analgesia. And obviously, when there are combinations of medications, as most people with chronic pain or even acute pain are going to have more than one medication that's addressing either an anxiety issue or the pain itself. And mechanistically, there's a lack of evidence evaluating the changes of the brain structure and or function and correlating that with the cognitive tests. These are biomarkers, and we should understand some of these biomarkers and their mechanisms in order to develop the therapeutic, better develop potential therapeutic targets. And of course, looking at the data long-term, or looking at the effect of the drugs or the health condition, whether it is multiple sclerosis, diabetes, or pain, over the long term, as there are changes in cognitive impairment and in the condition that may be causing more cognitive impairment with the addition of medications is critical. These are areas that need further research. As I say, it's almost limitless. And just to point out some of the patient-related factors, medical conditions, obviously any comorbid medical condition can contribute in a summation way, in a synergistic way, the effect on cognition. Depression is one example I've listed here. Social demographics, whether somebody's married or divorced, whether they live in poverty or not. Concomitant medications, daily functioning, we saw during COVID, the isolation, the socialization needs, how this impacts cognitive functioning and physical exercise are important. Of course, the genetic factors, as I pointed out, that may be contributing to the development of dementia, but also substance use disorders. That doesn't mean that you have an opioid addiction, but you may be an abuser of alcohol to some degree, or some of the recreational drugs. And what impact does this have then on the underlying cognitive functioning in people with pain or any other medical condition? So in evaluating this from a clinical perspective and looking towards future research needs, we need to have a patient-centered approach with regard to analgesics, and probably this is universal. We need validated pain assessment tools at the various levels of cognitively impaired individuals, so that we can focus on the optimization of pain management while minimizing the cognitive side effects with regard to either an intervention that is not a pharmacologic intervention, or if there is a pharmacologic intervention. Some of the key features for research are exposure to central acting analgesics that are including the dosing, the duration of therapy, concomitant medications. These are all critical to incorporate in the future longitudinal studies. And as Dr. Savitz indicated, there are now tools that will allow us to do this, and maybe something beyond a phase 3 that are extensions in phase 4 to obtain that data long-term into the years. So assessments of concomitant medication use should extend to include the long-term efficacy and safety data such as sustained pain control, cognition, and other aspects of daily function. I have here on the right some key features that are dynamically affecting cognition and should be considered in the design of studies. That is, what is the source of the pain? What's its etaology? What is the phenotype? And et cetera. Mental health conditions, social interactions. I've mentioned most of these, and obviously there are a lot of factors that can affect cognition, and they affect pain. And so pain affects cognition, and cognition affects pain. And each of these domains here of area can have some impact. So we have to take a higher view of this and take something off the table, but begin by doing a more thorough evaluation of cognition in these medical states. Mechanistically, I said one of the major gaps is understanding what impact this has, what impact pain and its therapies have on brain structure and function at various stages. So we need longitudinal studies here as well. So we may need to do more MRIs, but we also should coordinate that with good psychological tests, cognitive evaluation tests at various stages. And I think the conceptual framework here then is bringing me back to looking at whether it is pain or central acting analgesics or even peripheral acting analgesics. What ultimately what we want to know is what impact we have on cognition as well as pain, and what that balance or trade-offs are, and taking a look at all of the confounding factors that can either mediate or augment the cognitive impairment. So I want to mention, Dr. Savitz mentioned something about the FDA's request for more information on drugs that might have some impact on cognition. There is an opportunity perhaps for information to go into the package insert in section 12.2, which is the pharmacology area. The FDA guidance states that any biomarker or information mechanistically that can be informative should go into this section. That doesn't mean it's a safety data point, but it is important to take a look at the potential biomarkers from a cognitive effect that could be inserted into 12.2 section of the package insert. So I'm going to end here with these takeaways. Chronic pain, highly prevalent, most disease states that we are developing drugs for is going to have a subset of the population who are experiencing chronic pain, but particularly in the elderly adults. Studies have shown that there is a direct correlation between pain and cognitive impairment. Cognitive function is often under assessed and not incorporated in the pain management strategy or in the drug development strategies. So many factors can contribute to a patient's cognitive function. It's almost limitless. It's all of life's experiences. And so cognitive functioning should be assessed prior to treating patients and obviously in most states with drug development. Pain management approaches should be patient-specific based on cognitive functions, but we need that data and information in the package insert in order to best optimize our treatment. So the future research should include comprehensive assessments of pain, analgesic use, cognitive function, while considering the potential confounders, mediators, and moderators. Thank you. I'll turn it now back to Francisca, where we'll entertain some questions and answers.
Hopefully answers. No, thank you very much, both of you, for some really fascinating material that you presented. And just on that note, I think we've only got a few minutes. We've only got 5 minutes for questions. But given the kind of the really compelling arguments that I think you both made for inclusion of cognition, both in the assessment of pain, but also in drug development more broadly, I was just kind of curious to have your thoughts about what have been the kind of the barriers to this being done much more systematically than it has been, as Kenton alluded to in his talk. What are some of the constraints to this being adopted more broadly? And I'm wondering if I start with you, Dr. Webster.
Sure. You know, I think it's a big task. I mean, there are so many confounding issues. You don't hardly know where to go. Obviously, cost is an issue. It is a cost. If you choose one area to evaluate, you've got an infinite number other areas that need to be evaluated as well. So you need to start somewhere. But I think part of the barrier is, one, we've not really been that aware of the importance of it. And it is so complicated to understand all of the interactions. I think it's easy to just get stuck in the mud and not go forward. And then, of course, I mean, it's a black hole for expenses. So that I think I can understand why industry would be concerned about starting down one path. But I think at a very high level, I mean, taking a look at the impact drugs can have on reversing or improving cognitive cognition could be very helpful to somebody who's got a product that does that, and that could be a differentiator.
No, that's great. Kenton, I was wondering if you had anything to add on that. And specifically, I'm thinking about the potential role of technology to address some of those barriers to adoption that Dr. Webster alluded to.
Yeah, so I think, you know, in the past, I think there's both been a lack of awareness, a lack of some of the, you know, sensitive tools that were available, and also, you know, lack of examples where not having data has come back to bite you. So, you know, I mentioned the case of statins where, you know, 30 years and literally millions of patient years of use developed a post-marketing set of concerns where memory was thought to possibly be, you know, a problem, even though there was never any, you know, clinical data to suggest that, nor was there data to, you know, prove that there was not a factor. So not having the information at hand can come back to bite you even years later with, you know, a class warning black box about memory that, you know, wasn't really justified by the data, and then required additional studies for anybody working in this area. So I think some people think about managing clinical risk, and that is not asking questions that we don't have to ask. But I think sometimes, again, that's not the best long-term strategy. And now that we have the tools to be able to, you know, send people home with an app on their phone that can, you know, really collect valuable real-world data in a long-term scenario. I think the other piece is that people don't, you know, haven't been thinking of this as sort of a competitive differentiator. So if you work in an area where somebody has some data where there's a, you know, psychomotor slowing, and you have a new mechanism of action coming into that marketplace, you might be able to demonstrate that your drug has a cleaner cognitive safety profile and gets rid of that, you know, psychomotor slowing that could have real world consequences. So just like we've always, in almost every drug development program, we always measure blood pressure, we always do a lipid panel, we always do a whole lot of clinical stuff. But, cognition has never really been part of that. And I think it's something that people are starting to think more about. And they want to know, in this most important aspect of our life, the way that we think and interact with the world, that it's not being adversely affected.
No, that's great. And I know that we're up on time. This discussion could continue much longer. I'd like again just to thank both of the speakers for really excellent talks. And if there are any questions, any further questions that people would like to follow up on, please do reach out after the webinar, and we can certainly look to address some of those. So with that, thank you very much. And yes, and it's been a very educational experience for me, at least. Thank you.